Good morning, good afternoon, everybody. Really excited to have you all with us today. We have a really great presentation set up for you. We're going to hear a little bit about Memorial Health System and one of their many projects where they are using simulation as part of their Lean Six Sigma process improvement efforts. Todd is going to talk to us a little bit about a project around wait times in the emergency room and how they tackled that using the DMAIC process. If we can just introduce Todd. Todd is the administrator for quality and safety at Memorial Health System. What that means is he manages their Lean Six Sigma team and that entire program. He brought simulation in and is doing some really great work in this area. Of course, you know me, Brittany Hagedorn. I lead our U.S. healthcare efforts. So just a little bit of reminder, some housekeeping. You are all on mute, so you will not be able to speak up directly, but we really would love to hear from you. If you have any thoughts, if you have any questions, please pop them into the chat panel on the right-hand side of your screen. We would love to hear your questions. We will answer those all in the last 10-15 minutes of the presentation. Also a reminder, this recording, of course, will be available on Simulate Healthcare. You will get this in your inbox as well. Please do share with colleagues, friends, anyone who you think would find it helpful or interesting. With that said, I'm going to turn it over to Todd, and we can get started on the interesting work he's doing.
All right. Thanks, Brittany. Good day, everybody. I guess it's morning some places and afternoon in others. So let me just go ahead and get started. I'll give you the cursory background information of our organization that you see in every presentation. Up at the top here on this slide, you'll see this is a really graphic representation of our flagship hospital, Memorial Medical Center. We're actually a health system with 7 affiliates. We have 4 hospitals, home health, and hospice services, and behavioral health for the region. The reason you see this as a graphic is because we're doing a lot of construction right now. The whole front facade that's glass is currently under construction, and it will be completed in the next year or so, as well as some of the other areas here. But then over to the left, you'll see our new Memorial Center for Learning and Innovation, and that's where our quality and safety is now based. It's a 72,000 square foot building. We're in partnership with the Southern Illinois University School of Medicine, which is you can see their campus up in the top left-hand corner near the MCLI building there. So we're very happy with our with how we've got it set up, and I want to share with you some of the work that we're doing. We've won a couple of Quality Excellence Achievement Awards to the Illinois Hospital Association the last 2 years for work, some of it including simulation around reducing hospital-acquired pressure ulcers and reducing use of blood products. And then over in the bottom left-hand corner, you can see our quality and safety team. I am the follically challenged individual in the middle. So you have an idea of who I am, and that's our team. Okay, so let's jump into the some of the background and philosophy that we follow when we have implemented simulation. You know, we follow Peter Senge wrote this book, The Fifth Discipline. Some of you may have read it, but it's about learning organizations, and it talks about system thinking as the ability to see things as a whole or holistically, including many different types of relationships between diverse elements of a complex system. And to be a learning organization, you have to be able to see the whole, and you have to understand the whole system. And it takes cause and effect thinking to a higher level and encourages the user to see not just linear causal connections, but also the web of causal interconnections that come into play in real systems. And this is a philosophy we really follow because healthcare is extraordinarily complex, and we're dealing in real systems, complex systems, and we need to think beyond just you know, even static queuing models, which serve us very well for a lot of different applications, but we need to get more dynamic in thinking of how these systems interact with each other. And this is where Simulate has really benefited us and really helped us to understand that the cause and effect and the downstream effects of changes. So system optimization, you'll see the Donna BDM model here at the bottom, structure, process, outcome. That's adjusting the system or process inputs to produce the best possible average response with minimum variability. And that's our goal with simulation and with Simulate. We want to produce the best response and reduce the variation. And I'll show you some of the tools that we use in conjunction with Simulate to verify our findings. And then the butterfly effect, everybody's probably heard of this, the sensitive dependence on initial conditions where a small change at one place can result in large differences to a later state. Those of you that may have tuned in about a year ago, I did a webinar that was based around our redesign, actually, of the main hospital that I talked about in the first slide, and it was around the number of elevators we had from our pre-op holding down to our surgical suite, and we found that by adding just one elevator to our elevator bank, we could reduce downstream the length of stay for outpatient surgical patients by 30 minutes. So a 2 or 3 minute wait at the elevator translates to an overall 30-minute longer length of stay for an outpatient surgery. And so that's really an example of the butterfly effect. And so those are the downstream effects that you need to be looking for in your simulations. A note about failure in complex systems and how we go about solving problems in our organization. We view 3 types of failures in complex systems. There's procedural failures, which is not following a process that's defined. Single obvious mistakes. For those of you that have the statistical process control bent, it tends to be special cause variation. It's a one-off. It's something that happened outside of the system. And you usually can resolve that through plan, do, check, act, or corrective action. There's engineered failures, people, process, to the materials. This is your fishbone diagram. Tends to be common cause variation, so the only way you're going to fix it is by changing the underlying process. These are defined processes, and this is where we do a lot of our Lean Six Sigma work. And then beyond that, there are system failures, and this is the complex interactions between processes and risk factors. It's difficult to understand and pinpoint the cause and effect relationships, and this is where we bring into play discrete event simulation to solve those system failures. So let's jump into our case study here. In our emergency department, we have one CT machine, CAT scan machine down in the emergency department. We have one on the main floor of the hospital in medical imaging. The one in the emergency department, of course, experiences very high volumes. We have 70,000 emergency room visits per year. We're a level 1 trauma center, a tertiary care center. So it's a very busy place. We're in an urban environment, and we see all sorts of different traumas and those types of things come in. So and as many of you in healthcare know, we do CT scans on just about everybody. It's amazing how many we do. But in the past, the CT and the ED has used several experimental initiatives such as additional tech assistance and doing patient workups ahead of time to try to break some of those bottlenecks that we have. The department was no longer able to work up patients ahead of time as the staff were no longer available, and this was because of our increasing volumes. Our prior process work had been done, and we'd seen the benefit of having an extra FTE as a tech assistant, but as times are tight and money's tight, requests were unsuccessful. And the reason for that is, as administrators, we tend to say, go back and fix your processes before asking for more people. Makes sense, because the first thing most ask for when their processes aren't working is, well, we just need more FTEs. But we have to really question that in today's environment. So the CT has been front-loaded with moving towards more exams without oral contrast. Oral contrast is a different dynamic. It adds about 30 to 40 minutes to each case. So we wanted to take a look at how that affects things. Then we have additional project work showing more lab tests for fewer CT tests because of DVT, which is a growing concern, pulmonary embolisms, which can be very deadly. And then we have our stroke and trauma services, which compete for CT services. And we have a hierarchy, as you might guess, of priority for the CT scanner, with trauma being first and stroke being second. So those bump anybody else that are waiting for a CT scan. And then when the scanner is backed up, the patient flow process then moves patients up to medical imaging on the first floor CT machine. So it causes flow issues. When it's backed up, we have to go to our other machine. Now, one of the resolutions for this that was proposed was, hey, let's just buy another CT scanner and knock down some walls and put a second one down in the ED. Well, you know, that's fine, but it's going to cost a couple $1 million, and we don't know that that's completely the answer. So we launched a Lean Six Sigma project around this because we don't exactly know the factors and the outcomes. So we don't have a solution. And so we just follow our regular process. And I'm only going to take you through a few of the tools. I won't bore you with our entire project file on this because it'd be about 150 slides. But we'll just walk through a few tools in each of the phases, just kind of give you a flavor of what was done. In the define phase, then, we develop our business case. The wait times for patients causes delays in patient care, causes an increase in anxiety for the patient, a delay in receiving a definitive diagnosis, as well as delay in the treatment plan. And our Press Ganey results, we were only in the 30th percentile for ED radiology wait times. So the patients were feeling it, and they were reflecting that in the patient surveys. So we knew we needed to do something about that because as people become less satisfied, they start going to your competitor down the street, or actually, even worse than that, they start to leave without treatment and what we call LWATs. And oftentimes when people leave without treatment, they come back 3 or 4 days later, even sicker than they were, and their length of stay goes up, their cost of care, their complications, and it's really a bad thing. So when people present to our ED, we want to make sure they're getting the treatment that they need immediately. Our EDCT machine is the most used in our health system, of course, and so related to those LWATs is lost revenue. The contribution margin for every patient that leaves is about $250. So individually, not that much, but with 70,000 visits, if you have a left without treatment rate of 5%, then that's real money. So just to kind of give you the scope, we just looked at the CT department and the ED. Turnaround time, the CT exam ordered versus started. So from the time we just scoped it down to this one section, from the time it's ordered to when it started. We didn't want to boil the ocean and get too far downstream. Out of scope was our first floor scanner, our scanner over in our medical, our day surgery building, which is our Bayless building. The dictation process for the physicians, and then turnaround time results received versus discharge time. And then, of course, as many of you who are black belts and the like know, the first best tool to do is a detailed flow chart, flow diagram of the process. So here it is. Here's our ED-CT patient throughput diagram. As you can see, quite a few decision points and a pretty involved process with a lot of steps. So we need to figure out where the bottleneck is and start to remove the waste there. And so to finish up, define our project charter, as you can see here, we put in our problem statement. We looked at this, and we said our defect definition is any CT exam starting greater than 45 minutes from being ordered, and this came from some evidence-based literature as we did research on this project. And our goal, our objective was to reduce turnaround time from the CT exam ordered versus CT exam started. And for those of you that are Lean Six Sigma people, our Sigma score, baseline Sigma score was 2.0 of getting started within 45 minutes. So not real good, but typical of most healthcare processes that have evolved on their own, with a baseline defects per million opportunities of 53%, or 539,000 per million. So a lot of room for improvement. So as we go into measure, we did, and I don't have it in the slides, but we did a significant regression analysis to figure out where the bottleneck in the process was. So some statistical analysis and measuring the process and getting all the timestamps out of our ED system. And we found that this is where we should focus here. This last part of the process is the patient ready for exam. So it's patient waiting for the patient to be transported to the CT and prepped and put in the CT scanner. So here were some of our timestamps. The CT page to time the tech assistant sent was 40 minutes. So there's 40 minutes burned right there. the tech sent to patient arrival, 5 minutes, and so as you can see, this is a lot of time that's going on. So our average time, we were in a 49 minutes. So if we were looking at a Sigma score based on continuous data, we would actually have a negative Sigma score because our average time would have been outside of where we should have been. So 15 of 38 cases observed the patient was not ready. And so we move into analyze, and this is where we will do the simulation. So we did a 5 whys analysis among some other works. Why are the ED staff paging that a patient is ready? They assume patient is prepped accordingly and labs are completed. So as you can see here, as we drill down on this, what it comes down to is the resources needed to do it are not present or available in the department. We just didn't have the resources there. So we said, okay, how about if we simulate this instead of actually just hiring someone or buying a CT scanner, and let's see what our results are. So our critical X's or critical inputs are the patients are not ready for their CT and the ED upon page because the needed resources are not available to validate that the patient is ready. And we looked at point-of-care testing, so includes, this was some of our lab testing that we did as a critical input as well. So that's one of the things that's involved with it. So drilling down, here's our micro problem statement. As you can read through that, patient needs to have the proper IV in place, dress appropriately, restroom use, all these different things. When it's not complete, causes delay in patient care with increased patient wait time, averaging an hour from order to start. So these delays can be attributed to lack of resources in order to validate the patient is ready for the exam and the point-of-care testing not being taken advantage of in the ED. So as we developed our simulation goals here, our black belts started to formulate what did we want to do with the simulation. Well, we scoped it down to saying we want to determine whether the implementation of an additional tech assistant will improve CT turnaround time. This was kind of the big ask from our ED administrator to say, hey, can I take this to the COO and say, look, if we get an extra tech assistant, it truly will reduce our wait times, as opposed to, hey, let's just throw more bodies at it. And so that was our simulation model. We compared both a day and a week, so we wanted to see what would happen during the course of a single day and then a week, because we want to cover all sources of variation, and we know with that butterfly effect that if you go out a week, sometimes you get a very different result than you do just running it through a day, especially when you're looking at a area like the ED that is a 24/7 organization where it's just continuous. They keep coming. You don't close at the end of the day and then start new the next day. It's just a continuous stream of people. Now, is there, obviously it varies in hour by hour arrival rate, but it never stops. So we looked at data for May, June, and July of 2014. So we looked at a 3-month time period to really get a flavor of what our arrival rates were, and we checked it all for seasonality. And summer tends to be busier times for us, as well as February, March time with flu and those types of things. We compared the current state with 1 CT tech versus 2 CT tech assistants, and then it's based on the time the CT is ordered to the time it started. And so let me just bring this up. I'm not going to go too deep into the nuts and bolts of it, but what I really want to illustrate here is that you don't have to be overly complicated with building your simulation for it to be very powerful. In the past, I've done a lot of simulations that are geo-mapped, where we take the layout of the building, like the schematic, and we put it on there, and then we actually create the flow that it actually shows in the building. And that's a pretty cool thing, but you don't have to do that, especially if you want to really turn projects. You can always make it prettier later for presentation purposes, but we're just trying to get information out of this. And so, as you can see, we have our scanner here, the different activities. So the prep work and the transport work. Here's our queue. This is the arrival. So ED enter, the enter arrival times average every 10.5 minutes. It's a Poisson distribution. And we look at our task times. So that's the average is 3 minutes with an exponential distribution to get through this process. for that activity. Again, 3 minutes. Our scanner time, we have one resource available, of course, so we have that built in there. And then here are our resources, our techs. We have our CT tech, one there, and then our transport tech. Here's where we can change from 1 and 2. Now, I apologize in advance. This model has continued to evolve, so the numbers I show you from our results aren't going to look exactly like it does when I run it here, because we just keep building these things and evolving them. But if we go back here, we have our chart here, and if we run it, let me go back here to one tech. So I go to one resource, and then I run it here. And you can see just based on this, you have kind of this bimodal kind of distribution here. But if you look, the maximum time goes up to 240 minutes, and it's really backloaded here. And you have 24% within 25 minutes, so on and so forth. And again, I'll show you the true results we got, but if I shift this to 2, you can see how that really relieves that backloading. Max goes up to 230, and now you have about, what is it, 28, 30, 40, almost 50% there within 45 minutes. So that just shows, and I'll show you the editing route. So it doesn't have to be overly complicated, and this one actually wasn't. We've done some that are extremely complicated. We're doing one right now with patient placement that we had to go through and find the arrival rates for every single unit of the hospital, 17 different units, and build out their length of stay and all sorts of other factors. So, but this was a relatively simple one. So let's go ahead and take a look at the results that we have here. And this was our current state with one tech assistant. As you can see, this was through 1 day. And our maximum wait time was up at 130 minutes. And within that 45-minute block, actually, this one didn't look so bad. It was, 50, 60, 70% there. But look what happens when we added the second. So within 12 minutes, or 13 minutes, we went from 28% to 41%. And if you look here, the longest time a person waits went from 130 minutes to 95. And so this whole thing has been shifted to the left. Okay, the scale's a little different. But now 73% have a CT within 30 minutes of order. And if we go up here to up there to 45, we've improved a great deal. That's a 27% reduction in longest time a patient waits, and that was so that's our model. So we're saying, okay, if we added the tech assistant, we can expect in a day 27% reduction longest time a patient waits. So let's look at it over a week. Here's our pre. Highest was up to 270 minutes, 50% within 27 minutes. As we add that, moved up to 53% within 18 minutes, and our longest wait time dropped from 270 to 180, and that's 82% of patients are having CTs within 36 minutes of the order, and our goal is 45. So that really has moved that part of the process. That's a 33% reduction in longest time a patient waits, and so the model is saying, hey, if we do this, we're going to get some results. So as we moved into improve, then we want to say, okay, so what are the duties of this person? So of course we outline the duties. So here's the CT tech assistant, their duties. This is outlined for them. So we want to be very planful about how we implement, because we want to get the results from the model that was projected. Okay. And this is what we actually got. The CT tech assistant results. Here's a comparison before and after. The average time was an hour and 36 minutes for the whole turnaround, not just that 45-minute section, but that whole turnaround. And that's a 27% reduction in overall wait time from an hour and 36 minutes to an hour and 10 minutes. That's exactly what the model predicted for us, that we would see about a 27 to 30% reduction. And so we felt like playing the lottery that day. Our baseline Six Sigma score went from 2.0 to about 3.5, which for the Six Sigma folks know that that's a significant increase. You hit that 4 Sigma wall and you have to do some other things. But going from a 2 to a 3.5 is taking you from about 70% efficiency up to 97% of getting the results that you're looking for. So this is a big scale, so because it goes from 0 to 4 hours and 48 minutes, so it doesn't look as dramatic on this chart, but that's a 26-minute drop per patient. So think of a half hour less for every patient that goes through the CT scanner with 70,000 patients and probably 70% of them getting a scan. So here's the benefits from discrete event simulation. It requires deep process understanding. We want to avoid tampering in the process. It's really easy to do, as you know from Six Sigma work, to tamper, to intervene without process knowledge, which usually disrupts the process and actually makes it worse. If you keep sticking your finger in the stew, pretty soon you end up with more finger than stew, and that's the philosophy that we base our work on. We create a shared visual understanding of the process for all parties. So we can take this, we throw it up on our big monitors in our boardrooms. People can actually see the process working. Every time we do one of these simulations, we'll have physicians, we'll have senior executives sit and go, yep, that's exactly what's going on. And so it's really neat to have people actually see the process and say, yeah, that's what I experience every day. It allows for observational analysis and modification without physical intervention in a complex environment, especially in healthcare, because when you start messing with a complex environment and doing trial and error, you're affecting patients. And so the more that we can do in a virtual environment, the better. And that's why this has been very effective for us, and really why we've achieved such easy buy-in, because Simulate produces the projected results every time that we end up seeing in the real world, and we can do it all in a visual world without disrupting patient care. Pretty easy to sell that way. And then it supports improved decision-making through management by fact as opposed to management by intuition, using our data, using our distributions, using the way the real world works instead of just a bunch of us suits sitting around in a room coming up with a new idea and telling people to go do it and wishing them the best of luck. So our current projects, we have a lot of things going on right now, and we just keep ramping it up. House-wide patient placement, which I mentioned earlier. We have a lot of bottlenecks in our PACU, post-acute care unit in the DOR. The ED, a lot of holds still because we have issues getting people out of the hospital. Our census has been extremely high. We're bursting at the seams. We don't have enough beds. We have direct admits waiting to get into the hospital. So we have to find a way to get the people in the best beds. The right patient, right bed, right time, and that's what we're working on with a major simulation. We're working with the folks at Simulate to make that happen. Our pharmacy IV compounding production process, we need to make that efficient. We're moving from smaller batches. They've done large batches, and what happens in this compounding is if you make these IV bags for patients, oftentimes they're patient-specific and they're specialized, like some of these expensive cancer drugs, and you may batch them all at 7 in the morning and the order is not due to the patient until 3 in the afternoon. Well, something changes in that 8-hour period, and now that medicine is no longer applicable, and what often happens is those expensive drugs just get thrown out. So we're working on the IV compounding production to dial that in and to make sure we're right-sizing the batches and doing the batches frequently and having the proper amount of personnel working on that. Our ED intake process, we're working on that at one of our critical access hospitals, and so we're spreading this out across our system. In fact, we just networked our Simulate so that we don't have desktop applications anymore. We have it on the network so that we have a number of users that can get on at the same time, and we can share and we can show our screens to each other and put them up in boardrooms and those kind of things. Our system CT utilization optimization, so that's upstairs. That's in our medical imaging. We've done it now with the ED. We want to move it upstairs. Emergency department pod structures, so this is the way we triage patients and move them through the system. And then our ED admission handoff process. So you see a lot of things happening in the emergency department, but that that's that makes sense because it's the front door to your hospital, and right now about 50% of the patients come through our ED are admitted, so it's a major source of admission. And then all of the OR work. So we're just continuing to find these every day, and people will give us new ideas every day, and we're just working to really expand this knowledge. One of the other things that we're currently working on with our new Center for Learning and Innovation is integrating our engineering simulation with clinical simulation. We have a clinical simulation lab for the School of Medicine up here, and so they can run through procedures, they can do operations, they can do all these things in their simulation environment, and we can integrate our engineering simulation with that to streamline that process. And it's really, I think, going to create something very powerful for education and for process development. So that's what we have for today. I guess with that, we'll take questions, and I'll be happy to answer any questions you might have on our process and what we do.
Well, thanks, Todd, for the quick tour of all of your work. This is absolutely phenomenal. So excited to have everybody here to kind of hear some of your stories. Before we get into the simulation, can you talk a little bit more about this integration with medical simulation? I think you said you have a clinician who's actually the champion so that you can really kind of push that?
Yeah, we have a vascular surgeon who actually came to us most recently from Memorial Hermann, and he was at Duke prior to that, and he's really spearheading a lot of the research work that we're doing in our partnership in our MHQA, which is the Midwest Healthcare Quality Alliance. And so we're partnering with vascular surgery and with emergency medicine to be able to develop processes that we can then go and trial in a clinical simulation environment. So as we try new procedures, as we try new processes, and we want to put them in the clinical environment, they're well vetted out. We're really strengthening our R&D, our research and development about how we want to go about things. And I think that's going to be invaluable to our patient population and just to the research that we're doing and the publishing that we're partnering with our School of Medicine to get out in the world.
Nice, excellent.
Another aspect of that is that our black belts, then we use that as a training environment for our black belts as well, because with our observation areas, they can observe the clinical processes in simulation, and then they can, we can work through those and provide recommendations. So it's also a training ground for our black belts, and so there's a lot of benefits to combining those methodologies.
Great. So let me follow up on that statement a little bit. So you actually are bringing in a lot of new black belts, right? And how are you introducing them to process simulation and those tools? Is that skill set they're coming in with, or is that something that you're building within your team?
We are building the capability internally. We started our Lean Six Sigma program when I arrived about 5 years ago. They've done some statistical process control and kind of taken a little crack at Lean, but really we wanted to increase the level of sophistication. We know that it's a changing healthcare environment. We know that Health and Human Services has a goal that by 2018, 80% of all Medicare payments, Medicare Medicaid patients payments will be made on quality as opposed to quantity, and as we see the fee-for-service environment sunsetting. So we knew that we had to get better at our processes, and so I came from the outside. I came from a health system in Nebraska where I was a black belt, but really was asked to start up the program here. And so I started recruiting people internally, and we launched a couple of Greenbelt cohorts, and we just started training Greenbelts internally, and that was from nursing. It was really all across the organization. And in the last 5 years, we've trained about 110 Greenbelts now, and it's not an easy training. We've made it very rigorous. We've based it so that it's the goal is if you pass our certification, that you could go take the ASQ test and pass it. So it's 8 days of classroom training spread out over 4 months. You have to complete a project. You have to pass an exam to get your green belt. So we wanted to build that competency in the organization. We wanted to build it on the ground. And so we've been training green belts. Then we've trained white belts, which is just a one-day training trying to get to the frontline people. And we've trained about 700 people. Our organization overall, we have about 7,000 employees. We've trained 700 people as white belts in the one-day training, and we offer that training quarterly. Then we have our black belt training, so the top green belts will go through we'll often be recruited, maybe the top 10% of each green belt cohort, which is usually 15 to 20 people, will be recruited to become black belts. And then many of those folks become full-time quality people. So we've had, right now I have a black belt that is an occupational therapist that actually left a management role as an occupational therapist to come be a black belt, just because we want to make it, we want a talent community coming from our quality area. So if people really want to get into higher level management, the way to do it in our organization, just like Jack Welch espoused, is to come be a black belt for a couple of years, and then you can go off and be a director in an operational area. We had one person who was a director of planning and strategy left her position as a director to come work for us as a black belt, a non-management position, for a year, and then she took a job as a director in the OR, which is actually a nice career move for her. So we're embedding these folks around the organization and building them up within the organization and training them. Now, as far as Simulate is concerned, we have now built that in as a training module within our black belt training. So anyone who goes through our black belt training will now receive about a day of training on Simulate, and then all the support that they need to continue to learn that, because we think it's such an integral part of what we do, and an understanding. And it really helps people learn about statistics that may not have a strong statistical background, and it really kind of makes it simple for them, and puts it into a real-world environment where you can see how they're actually behaving. It's not just theoretical numbers in a book. So it's really cool. We're getting a great reception. People are wanting to take the Simulate class. We have other people that aren't in black belt that are asking us to take it through our organizational development process and taking it as a class. So we're looking at developing a class there as well.
Interesting. So I guess the question in my mind then is how is Simulate been received originally when you first started using it, and now that you've started training people and you've started embedding those folks, those black belts, in the rest of the organization, are the types of projects you're doing and the kind of reception you get, is that changing, I would assume?
Yeah, our organization, I mean, it was pretty unique. They've always had a good culture for change, but I had to prove it because I had done simulation in the past, and just a little anecdote, I went to my boss, who is the Executive Vice President and Chief Operating Officer. At the time, he was Vice President of Quality, and I was the Director of Operations Improvement. And I said, hey, I'd like to buy this software because I think we could get some good out of it on some of our processes. And he asked how much it was. I said, yeah, go ahead and get a copy. And then, but then the pressure was on to kind of, prove it. And the first simulation that I did, the guy that was the Executive Vice President at the time came and he popped his head in my office, and it was a Monday, and he said, hey, could you do a simulation on patient flow for the new build-out? And this was the elevator project. And I said, sure, when do you need it? He said, how about Friday? Well, simulation. A simulation that big is at least 60 hours of work, and this was Monday afternoon, and he needed it by Friday. So I pretty much locked my door the rest of the week, and I finished it. And finding the elevator bottleneck was kind of an accident. I was really looking to see if we had enough PACU beds, and we found that the real bottleneck was in the elevators. And I was fortunate. I was able to take it, and they bought it. they believed it, and I put it in front of the architects then, and they were like, oh, wow, this is actually pretty cool. And so they went and they built it into the plans right away. So there was quick buy-in. because I think because we could show them the numbers and we could show them the data and say, look, this is just how it behaves in a complex system. And they said, well, I mean, it is what it is. And so now it's really just become kind of a daily part of life. We do it all the time. There really isn't any questioning of it anymore. If they say, oh, we did a simulation around this, you know, they say, oh, what'd it show? And that's pretty much where we're at now. So it's widely accepted, it's widely used as valid because we validated it so many times that we've shown, hey, this is what the model is showing us, and then we come and we get the real world results. It doesn't take too long for people to believe it.
Sure, absolutely. So I just want to get back to the project itself. I've had a couple of questions come in. First of all, a thanks for sharing. Somebody was just heading out and they wanted to say thanks for putting together the presentation. So it's always great to hear. Another question is, how long did it take you to actually get from the start of the define process to the end of the control? Right? What was that kind of timeline for you in this project?
Oh, sure. We keep our projects to 120 days. So because we want to keep the scope appropriate, so we say if we can't get it done in 120 days, it's probably too big of a scope. So that's our goal with every project. Now, to be honest, some training projects take a little longer just because people are training. But once you're trained up, we expect it to be done in 4 months. And we have toll gates monthly, and that's a set date. It's not at the end of each phase. It's every 30 days, every month, you have a toll gate. No matter where you're at, you come and report out, and that helps us to keep on track. And if you come and say, well, we haven't made any progress, then the question becomes, well, why? What barriers do you have? What do we need to break down? So we found that moving from having toll gates after each phase to having toll gates at a set interval every month has helped to speed up the process and keep us moving. So obviously there are some big black belt projects that take longer, and we're cognizant of that. But this one was really about I would say max 4 months, because actually the person working on it was working on her black belt. She wanted to get her project done.
A good motivator.
Yeah.
Okay, so the other question about the project specifically that just came in is, how did you validate the current state, and how did you know that you had enough detail?
A lot of it was voice of the customer. We pulled the data from our ED system. Of course, we have all the milestones of patients coming through, and we know that really 30 data points is statistically significant, but we looked at 3 months worth of data, so we knew that there was a ton of data. How many patients do you have go through your ED a day when you do 70,000 patients a year? So we had all that, and then we validated it with the customer. We sat down with the folks in the ED. We sat down with physicians. We sat down with techs. We sat down with the administrator of the ED and its nurses, and we always vet these things out. We go through them with them so that they can say yes or no, I think that's right. I don't think there's enough detail here. Here are the other factors. As part of the Six Sigma process and understanding the flow of the process, we always sit down with our customers, because they're the people in the best position to tell us whether there's enough detail or whether there's some unknown factor in there that we need to be considering. And they're certainly not shy about telling us that, well, did you consider this? Did you consider that? So that's the voice of the customer is our main vehicle, along with our data analysis.
Okay, great. So question from Eric, and that is, with the many requests that come into you, how do you prioritize? And then second follow-on question, that how do you ensure that they act on the evidence that you provide? Two pieces.
Yeah, those are good questions. The first one, prioritize. We have developed, we have a scoring system as far as projects are concerned. That we have a council basically of black belts. There's 13 black belts in the organization, and we go through, we meet once a month to vet out projects and to score them. And we have an algorithm that we've developed, and we kind of adapted it from Tom Pye's book. If anybody's familiar with that, the Lean Six Sigma Handbook. That was really kind of the basis, but we've altered it to really fit our needs. How does it tie to our strategic priorities? Do we have executive sponsorship? How many times has this come up as a problem? That, you know, that's a force multiplier. If it keeps reoccurring, do we know the answer? What's the financial or the qualities? Those kind of things. So we score it out and then we prioritize it, and it gets a numerical grade each project, and then they're prioritized. We have a database that lists them out as the priorities. So other things, you know, we're not immune to the this needs to be done now syndrome, and you know, you have to leave some space for that. You have to keep some capacity open for those big things that come up, and we're aware of that. So that's the first part of the question, is that we score everything out. And the second part of the question, could you repeat that again, please, for me?
The question was, how do you ensure that they, I'm assuming management and the other team members, act on the evidence that you provide?
Oh, sure. That's part of our control and follow-up. Our toll gates, each project has to have an executive sponsor, and our executive sponsors have to be at the system leadership level, and that's one of us. It's the top 27 executives in our healthcare system. So it has to be a very, very senior person that is sponsoring the project. And in fact, when it comes to these simulations, our administrator of our emergency care services is one of our biggest champions. He's coming to us all the time and works closely with us saying, hey, can we do a simulation on this? So buy-in's really not a problem and follow-through. But for the other part of the Lean Six Sigma, we oftentimes we may have our CNO as the executive sponsor, or our COO, or our CMO, and so there is a top-down sponsorship to help ensure things get done and pushed out once the evidence is put into place. So I guess that's probably my best answer, is that we make sure we have strong executive sponsorship that will help to drive the change.
Absolutely. Okay, one more question. I think we talked about this briefly at the start, but a question from Scott about how large is your staff?
My staff, personally, as far as our quality and safety, we have 11 people here centrally, but that includes our safety team and our environmental safety team. But our patient safety director is a black belt. She's a physical therapist, and she completed her black belt and then took the role as director of patient safety. So we have a lot of ties between our safety and our operations improvement. And then our operation improvement team, right now we have a director, a system director, who is a master black belt, and then we have 4 full-time black belts. But we also have these other black belts embedded in the organization. One of our black belts graduated from our central quality areas, so she's now the director of nursing operations improvement. Then the other one that I mentioned earlier is the director of surgical operations improvement. So she, because those are major areas, we've embedded black belts full-time in those areas to run that part of the business. We have a black belt full-time in lab, and they all have a dotted line to me still, and they're part of our black belt council. So we have them spread out across the organization. In some of our affiliates, we've got one black belt that's just finishing up in one of the other hospitals, and we've got a couple more in training. So we kind of have a little bit of a hub and spoke and a little bit of a centralized, decentralized model, but we have a very strong group that's centralized. It's not huge, but it's effective. And then these black belts in our centralized model, every green belt project done in the organization has a black belt mentor. So of our 4 full-time black belts and our director, they're all overseeing a book of green belt projects that are going on. So they're actively mentoring the green belt and overseeing that, so that it makes sure that we're getting everything done and getting the toll gates scheduled and helping them with any issues.
Okay, so I guess the follow-on question there then would be, how many projects are they maybe running themselves versus overseeing? I mean, how do you how do you make sure that that balance is appropriate?
Yeah, our goal is to have them running 3 or 4 projects at a time themselves, and then they're overseeing maybe that, well, maybe 5 to 10. So because overseeing doesn't take nearly as much time.
Sure.
But right now we have about 70 active projects going across our health system that are overseen or being actively led by our black belts. So, if you do the math, their book is each about 15 total. So they probably, some of them have 4 or 5 projects they're doing themselves, then maybe 10 they're overseeing.
So you're keeping them busy then.
Yeah, and
good.
A lot of them. It just depends a little bit also on the personality too. Some people say, "Hey, just give me all I can take," and because one of the things that helps to inspire that is we really publicize everybody's work, and so it's a great way from a career standpoint to get yourself noticed by senior leadership, because if you're a black belt and you execute on a project, you're going in front of the CEO and presenting, and you're getting a lot of kudos for that. So they've developed a lot of credibility, and our CEO just commented in our system leadership team meeting yesterday about how impressed he is because he walked by and he saw the team with a simulation up on the monitor and doing all this stuff, and so to get that recognition by the CEO, who knows everybody's names and who knows what everybody's doing, is really important to people.
Yeah, absolutely. Great. Okay, so I'm going to wrap things up. I just want to remind everybody of a few things. Thank you so much, Todd. This has been a phenomenal conversation. If you have any other questions, folks, please do feel free to shoot those over or join us on the LinkedIn group, and we can answer them there as well. That would be really fantastic kind of forum to continue this conversation. Because I think, Todd, you've really opened up a can of worms here, and that this is just one project, but there's so much more that you're doing that we can maybe learn from.
Mm-hmm, absolutely.
The LinkedIn group is the Simulate in Healthcare group, so if you search for that, please join us there and join the conversation. We tend to have information about the webinars, upcoming training events, all of those sorts of things are all posted there, so it's a great forum to kind of keep tabs on what's happening in the simulation space. The other thing I just want to remind you, May 21st is going to be our next webinar. That's a Thursday, so we're moving away from our Tuesday for this month, and it's going to be 11 a.m. Eastern Time. And David Gilding is going to be presenting about a model that he built looking at obesity, and particularly how the disease is progressing. Given his population, he was looking at a specific region and looking at how obesity was going to affect the number of services and the capacity that he was going to need to commission for that community in order to be able to meet the needs. So really looking at kind of the 5 to 10 year vision of how are we going to serve our community for this particular subset of patients. So that should be a really great presentation, really all about how do we look at population health, how do we think about serving population needs. I'll also mention we have 2 other events coming up in May. We have a Chicago training, May 21st, 22nd. So if you are just getting started, or if you have colleagues who need to kind of get introduced to Simulate, learn the basics, or refresh your memory, join us for that in Chicago. That's coming up in a couple weeks. And we also have a Toronto training that's coming up. That's going to be a one-day event, and that workshop is going to be looking at how do we integrate simulation into Lean Six Sigma programs, how do they work together, and looking at process redesign specifically in healthcare. That's going to be more geared towards folks who have some experience with process improvement, have some exposure to simulation, and really want to get into the nitty-gritty of how do we actually make this work, how do we make it function. So we're going to look at some specific case studies, get some hands-on experience with some projects. So that is all going to be coming up in the next few weeks. That's also in May. The week of the May 19th, I believe, is the date. So if you are at all interested, check it out on the LinkedIn group, join us on the website. And just a reminder, I just said the webinar date is going to be May 21st. So do join us for that. I think that's all my announcements. Thank you so much for being here today. Todd, thank you for taking the time to share all of this great work. And we will talk to you all next month.